King Maud Al-Aziz Medical City. It is our pleasure today to welcome Professor Stamatopoulos from Greece. He's the director of the Institute of Applied Biosciences. He, as a brief background, he had his MD and PhD degrees both from Athens University, and has had a number of administrative and leadership positions over the years, with the most recent position being the director of the Institute of Applied Biosciences. Very well published with more than 250 peer-reviewed publications, many of them with high impact factor. Today, what we will hear is about the treatment of chronic lymphocytic leukemia, and with special focus on the new EHA guidelines. As you know, the amount of evidence and treatment options that have emerged for CLL in the last few years has been extensive, and to some extent, we're hoping to have a similar outcome in CLL patients to what we would see in CML patients. Although that being said, with the number of options that we have, the optimal treatment strategy is not always ideal, and a number of factors have to be taken into consideration. So with that in mind, Professor Stamatopoulos is going to walk us through this. He will have a number of questions, polling questions throughout his presentation. Where we will elicit your responses, and we're going to have some discussion around that. And of course, at the end, we will have our usual Q&A session, if there are any. Of course, for the Q&A, please, if you have any questions, type them at the Q&A box at the bottom of your screen, and we'll make sure to cover all the questions in the time that we have. So, I would also like to acknowledge the sponsor for today's talk, which is Jensen. Without further ado, we would like to hear from Professor Stamatopoulos. The floor is yours, Professor.
Thank you really very much for the kind introduction. It is my distinct pleasure to be again with colleagues from the Kingdom, though only virtually, unfortunately. Now, the question that I'm supposed to try and address today is how research may inform the clinical practice in CLL. Here are my disclosures. So, we would like to move fast towards a personalized approach, towards following a personalized approach to CLL patient management. Obviously, this relies on 4 different pillars. The disease profile, and we'll be talking quite a lot about it soon. The patient profile, in other words, the overall patient fitness, the overall patient condition, associated comorbidities and medications. The profile of the drug. So, in other words, when we've decided about possible options to try and consider whether the toxicities associated with a given drug or drug combination would be somehow acceptable or would not be too risky for a given patient. And finally, but very critically also, what the patient prefers. Now, let's start with a fact regarding the tumor biology. We have known since a long time ago that patients with TP53 aberrations respond poorly to chemoimmunotherapy. So chemoimmunotherapy should be avoided in those patients. But how many are those patients? If we focus on patients in the frontline setting, and we apply FISH for deletion of 17p and Sanger sequencing for detecting TP53 mutations, around 14% of all patients, this is the pie, corresponds to all patients in the frontline setting. So there will be a pink slice of around 15% bearing such aberrations. If, however, you apply a highly sensitive next generation sequencing methodology, in addition to the pink slice of the pie, you get a purple one This corresponds to patients who are negative by FISH or negative by Sanger sequencing and yet carry small clonal populations bearing TP53 pathogenic variants. And it is obviously a very different result, having 15% or 30%. So clearly, the deeper you go, the more you will find. And the obvious question is, what should we do? When it comes to risk assessment, it's not only TP53. Immunoglobulin genes are important. And we have learned in these recent years that patients with unmutated immunoglobulin genes, hereafter designated as UCLL, these patients experience a major benefit from targeted agents. How many are these patients? And it's simple. Only 1/3, give or take, carry mutated immunoglobulin genes. They are MCLL, whereas the remainder, 2/3, are unmutated CLL. So, novel agents confer a major benefit to at least 2/3 of all patients with CLL. But mutated CLL are a non-negligible 1/3. So, within mutated CLL, there is one group shown here in red that we call subset number 2. I remind you, the immunoglobulin genes of these patients are mutated. So it is a substantial fraction of all patients requiring treatment, and more particularly a substantial fraction of patients with mutated immunoglobulin genes. Now, we took advantage of 3 different large academic randomized clinical trials with chemoimmunotherapy. CLL8, comparing FCR versus FC, CLL10, comparing FCR against bendamustine, and CLL11, where the Germans compared chlorambucil versus chlorambucil plus rituximab or obinutuzumab. And we looked at the survival, the overall survival, and we came, a really remarkable thing emerged. One group that we call subset number 2, that I've described a minute ago, and concerns patients with mutated immunoglobulin genes, does very poorly. It is the green curve that you see here on this survival plot, which is why we concluded that these patients who are poor responders, although representing mutated immunoglobulin gene CLL, should be recognized. And obviously, we concluded that not all of these patients with mutated immunoglobulin genes are equivalent. So, how to sum up when it comes to prognostic markers in the context of treatment? The IWCLL guidelines tell us to always test for deletion 17p by FISH, for TP53 gene mutations, and for immunoglobulin genes. And these biomarkers are important. They have been identified as important in the chemoimmunotherapy era. But we have made great strides since, and we have novel agents. So how can we summarize what is relevant today? I would say that these biomarkers are very important if you consider time-limited therapy. In other words, therapy that is based on venetoclax. Because we have seen that TP53 patients with TP53 aberrations are really losing the response more frequently than the rest. In contrast, these biomarkers have limited value when we talk about continuous treatment. In other words, treatment based on BTK inhibitors. Why? Because these aggressive clones respond rather well to continuous BTK inhibition. For the remainder of my talk, I will be focusing on what happens in young and fit and elderly and unfit patients, but amongst the many, many trials, I will be very selective. So young and fit. This is one recent trial that, in my view, is very important because it compares a chemo-free regimen, ibrutinib plus rituximab, versus chemoimmunotherapy in young and fit patients. So it's ibrutinib plus rituximab against FCR. And it is very important because we get a significant benefit in both PFS, but importantly also overall survival for the chemo-free combination of ibrutinib and rituximab. I remind you, FCR was previously considered as the gold standard for young and fit patients. So it is very important that the chemo-free regimen outperforms FCR. Now, what about elderly and unfit? Here, the very critical question is what happens in the long term with ibrutinib in the front line. This is the RESONATE-2 trial setting ibrutinib as the gold standard for this elderly population. And I would say that it is very important that with a very long follow-up of 7 years, we see that more than 60% of patients are alive and progression-free. We have seen that ibrutinib overrides the effect of unmutated immunoglobulin genes because it's equally effective in mutated and unmutated CLL. Response deepens with time, and importantly, only 16 patients, 12% of all, progressed on ibrutinib. Finally, when it comes to staying on the treatment, more than 50% of patients remain on ibrutinib because most adverse events were effectively managed with dose adjustments. RESONATE-2 excluded patients with TP53 aberrations. So another obvious question is what happens with these patients on ibrutinib in the frontline setting? And thankfully, today we have the results. We have them from the NIH phase 2 study, where the follow-up is now very nice, 6-year follow-up. And the black line is the overall survival of these patients. As you can see, we are now at more than 80%, and the progression-free survival is more than 55% at 6 years. This is remarkable, considering that with chemoimmunotherapy, these lines would have collapsed, would have dropped at no longer than 2 years. Having this result in the frontline setting is truly reassuring, truly very promising. But it's not only ibrutinib when it comes to BTK inhibitors, it's also acalabrutinib. And with acalabrutinib, we are seeing also remarkable results. This is the comparison of acalabrutinib or acalabrutinib plus obinutuzumab against chlorambucil and obinutuzumab. The result is truly impressive for the chemo-free combination of ibrutinib and obinutuzumab, but also for acalabrutinib as monotherapy. Novel agents include also venetoclax, the BCL2 inhibitor, and we've learned what happens in the frontline setting thanks to the CLL-14 trial, where the Germans compared venetoclax plus obinutuzumab against obinutuzumab plus chlorambucil. The difference in outcomes for progression-free survival are truly impressive. We have not yet seen an equally impressive difference in overall survival. We will need, obviously, and probably rather more follow-up, but still, this is a very promising result again. Having said that, as I've already mentioned, patients with TP53 aberrations, either due to a deletion of chromosome 17p on your left, or due to a mutation of the TP53 gene on your right, appear to experience less benefit from the fixed duration treatment, because the green line on your left, these are patients treated with venetoclax obinutuzumab and bearing a TP53 deletion, are doing badly. And the same goes for patients with TP53 mutations on your right. So fixed duration treatment does not appear to be the best possible idea for a patient bearing TP53 aberrations. How to wrap up about where we currently stand and what to expect for the near future. Novel agents outperform chemoimmunotherapy in the vast majority of patients. So currently today, the choice of a new drug depends heavily on the pillars that we mentioned: tumor biology, safety profile of the drug, and patient preferences. What do we expect for the future? Obviously, the idea of continuous treatment is not very appealing. So we would like to stop treatment at some time, and this is not possible with monotherapy. So combinations of novel agents will probably be the new treatment paradigm. And we do have excellent data from single-arm studies with a combination of a BTK inhibitor, ibrutinib or acalabrutinib, and venetoclax, plus minus obinutuzumab. What is a vision for the treatment of patients with CLL? First of all, to eliminate chemoimmunotherapy. I cannot ignore the fact that chemoimmunotherapy has many complications, infections, hematological toxicity, but also long-term adverse complications. Just remember secondary AML and secondary MDS. We need to achieve a high undetectable, measurable residual disease rate, because only through that we may aim at the cure of CLL. We should understand better how to manage, how to avoid in the first place, but also how to manage refractoriness to BTK inhibitors and venetoclax. We should better understand clonal evolution and Richter's transformation and find ways of managing these patients. Obviously, we need to start thinking of curing patients with CLL. That was undreamt of no more than 7-8 years ago. But even if we cure patients with CLL, this is not the end of the story. These patients are profoundly immunosuppressed. So we must do something to improve or to promote immune reconstitution, because this will mean eliminating autoimmune complications and eliminating second cancers. In the end, if you ask me to summarize it in only 6 words, I would say that my vision is for a treatment that will be time limited, risk stratified, and importantly, response adapted. So time limited will be guided by the quality of the obtained response, and the duration of the treatment may have to be prolonged in a patient where we get MRD positivity, or can stop for a patient who has achieved that. So it will not be fixed duration, but instead time limited. Thank you really very much for your attention. That was my overview. And now I'm really very happy to receive questions, but also comments.
Excellent. Thank you, Professor, for a very nice overview. If you want, maybe we can do the polling questions first that you have, and then after that we can look at the audience's questions.
I'm perfectly happy with that. So
sure.
I will now need 2 things: a very active commitment from our participants, from our attendees. I really count on you. And also support from our technical team. I know they are great, so I do not anticipate glitches. So can I have the first question, please? Now, which of the following biological profiles corresponds to higher risk CLL? You have only one choice. And here the answers are TP53 aberrations, immunoglobulin unmutated status, subset number 2, all of the above, none of the above, it depends, or I do not know. Please, you have 15 seconds to vote. Please start voting now. You have 10 seconds. 5 seconds. Please, let's close the poll. And may I kindly ask you to show us what we voted. So it's really a majority going for all of the above. And I'm very happy for that. It is also a group, 1/3 of us, 37% of us, who say TP53 aberrant, so they don't really care for the remainder. And it's also 4% who say it depends, 4% who say none of the above, and 4% who say I do not know. Would any of you like to comment? You are very welcome to comment, because I have here a secret for you. But I would like to hear if you have anything to challenge or to say or to object to this vote, this polling result.
I think our attendees have only access to the Q&A box. But we can, me and yourself, have a discussion around this if you like.
So, Dr. Damlaj, what is your reaction to what you've seen?
So just one thing to keep in mind, some of our audiences are allied health work professionals, so they may not have deep understanding of the topic, the fine details of what you presented. So they may be seeing this for the first time.
They responded beautifully, though. I mean,
exactly. I'm just reflecting. Absolutely. I'm just talking about the 12 or 13% or so that responded in the miscellaneous section.
I promised you, though, Dr. Damlaj, that I have a secret. And my secret is that my answer would be, it depends.
Yes.
Because in the end, when we speak about the risk, it should be the risk in relation to the treatment.
Yeah.
In other words, TP53 aberrations and are mutated immunoglobulins, and subset number 2 are very bad, but they are very bad if you think about chemotherapy, chemoimmunotherapy.
Yes.
With novel agents, the outcomes of these patients have improved amazingly. So, wouldn't you agree that it is important to make a distinction between prognosticators versus predictors of response to therapy?
Yes, yes, absolutely. They're both important, and they're both they can be mutually exclusive, so they don't necessarily mean the same thing.
Yeah. So, and then I would say that what I mostly care about is not prognosticators. What does it mean in the end to tell your patient, you know, your prognosis is good? You may be proven wrong the next day,
yes,
but it is important to know that your patient has a TP53 aberration, because then would you treat your patient with chemoimmunotherapy?
Yeah, I agree. Yeah, no, the answer is no, you would not. On the issue of one thing that comes to mind, the way we test TP53. So what is in routine clinical practice is essentially FISH, and Sanger is available, but it's not something that is done routinely, at least where I practice, on all samples. And of course, the next question, then the next factor after that is detection of TP53 aberrations using NGS. So yeah. what I wonder is that, of course, because with the different technologies, the sensitivity of the test increases, which means the clone size is smaller. So do we think that a TP53 aberration detected by NGS, but not FISH, would carry the same prognostic implications, or we do not know?
Perfect. So you made a beautiful segue to the next two questions. And can I have the second one, please? To our technical team, could we have the second question, please? Thank you. So the question for you to express your view is whether low-frequent TP53 mutations are prevalent. In other words, if we see them frequently. And here your options are yes, no, or I do not know. Please vote starting now. 10 seconds. 5 seconds. Please close the vote. And can we see the polling result? Very nice. 57% of you said yes. 19% of you said no. 24% of you said, I do not know. And here, obviously, the question is, the burning question is what we mean by low frequent. Is there a cutoff? And here the politically correct answer is that we in the European Hematology Association have proposed that when you apply NGS, you should report above 10%. And why that? Because the data, the evidence about TP53 originated with Sanger sequencing, not with NGS. Now, if you are doing everything great on a good day, the sensitivity threshold of Sanger sequencing is 10%. So we played it on the safe side and we said, stick to 10%. But I'm a co-author of these recommendations, and I'm a bit ashamed of myself because we also said, if it is between 5 to 10%, then you can report it, always with a disclaimer that we do not really know and we need to have more evidence. So if we have a cutoff at 5%, obviously we will detect many more than with Sanger sequencing alone. If we go down to 2%, we will detect even more. If we go down to 1%, we will detect even more. But here we come to two major challenges. Are the results reliable? Who knows? Unless a lab validates the result with another methodology, like digital droplet PCR, and knows that, yes, we can go as low as 2% reliably. And second obvious question, what do we know about the clinical significance of these mutations? Let's see what we know about these in the next question. So to our technical team, can we have the third question, please? So I would like to hear your view regarding the question as to if these low-frequent TP53 mutations matter, if they are significant or not. So your options are yes, no, it depends, or I do not know. You have 15 seconds, and please start voting now. 10 seconds. 5 seconds. Let's close the poll, please. And can I please ask for the results? Wow, you are a truly great audience, because this is the correct answer. You say it depends, and I admit that I also voted the same. So what is your reaction to that, Dr. Damlaj?
It depends on the treatment that you decide to give, I guess.
But also on the robustness of the lab result. I would also like to add.
Yes, yes.
So I will ask you a question. If your lab sent you a report that they found a pathogenic TP53 variant with a variant allele frequency of 6%, would you care about that?
This is tricky. It depends. This is again where it depends on what the patient prototype and what they can tolerate. So, and also depends on the mutation profile of the heavy chain immunoglobulin. So if it's a mutated heavy chain immunoglobulin and it's a young and fit patient, and I have the 6%, this is probably the hardest scenario where you're kind of unsure what is the best treatment. I have to admit, it is, that being said, the 6% is a difficult number to ignore and pretend that it doesn't exist. So I probably will take it as a true and significantly mutated gene.
Dr. Damlaj, I'm 57 years old, and suppose that I was your next patient with disease progression requiring treatment. I'm reasonably fit. I don't have any other comorbidities, and you are testing me and you find that I'm immunoglobulin gene mutated. I do not belong to subset number 2, but then the lab tells you 6% TP53 low frequent pathogenic variant. Would you give me FCR or something else?
Yeah, so this is the exact scenario where this is probably the hardest scenario. The other scenarios will be easier, essentially. So if you had an 80-year-old, for example, or
no, I'm talking about myself.
Yourself, yeah. So this is exactly what the toughest scenario to deal with. But like I said, I think it's important to ignore.
Yes, but what I'm asking you, doctor, what will you give me? What will you tell me?
Most probably, I'll depends on the other comorbidities. If there's hypertension, atrial fibrillation, etc. But probably BTK inhibitor, so either ibrutinib or acalabrutinib for now.
Because I'll now report to all of us a true case, not myself. We had a patient who was 57, had the exact same profile that I reported, no comorbidities, IG mutated immunoglobulin genes, deletion 17p negative, TP53 mutation analysis by Sanger negative. That was 2015. We gave FCR, and the patient had a really bad response with fast disease progression. So at progression, we tested for TP53 mutations by NGS.
Okay.
And we found a pathogenic variant with an allele frequency of 33%, so truly high.
Yeah.
And then we said, let's go back.
Go back and test the original one.
And test the original before FCR. And do you know what? Here we found the same pathogenic variant at 6%. I didn't mention 6 for whatever reason, but I still remember this patient. In 2015, we didn't have NGS. In 2016, we had it. So it's not a result that I would ignore, but that would mean that would, require that the lab know their work very, very well. They participate in external quality assessment schemes, and they provide to the physician an accurate lab report.
Interesting.
So, continuing on the issue of TP53 aberrant CLL, can I please have question number 4? Our technical team, can we have question number 4? Thank you very much. So, what would be your preferred frontline treatment for a patient carrying TP53 aberrations? Your options are treatment that is based on BTK inhibition, a treatment that is based on BCL2 inhibition. It depends, or I do not know. In other words, continuous BTK inhibition, fixed duration, BCL2 inhibition. It depends, or I do not know. Please vote starting now. 10 seconds. 5 seconds. Let's close the poll, please. So now we have half of you voting for BTK inhibitors and a substantial 41% saying it depends. Dr. Damlaj, if you don't mind, what did you vote?
So I voted for a BTK inhibitor.
Why do you think some of us voted for preferred it depends?
I guess that they would want to know more about the patient profile, comorbidities and the like, probably also more, and their preference. Would they like a continuous treatment versus a time-limited treatment? Also, probably the financial considerations and the coverage could be a factor, an important factor. And this is where it depends on what the coverage is, and the treatments are all expensive, but 12 months of treatment is different than continuous. Patient preference also, I remember recently a patient who was a frequent traveler as a businessman, and he just couldn't afford to stay in town for intravenous treatment. An oral treatment is a much more convenient option. So I guess this is where the factors to consider before committing one versus another.
And I must say, I can't agree with those who voted for it depends. One thing is very correct, that fixed duration treatment is not optimal for these patients, but still we can't ignore the patient profile. In other words, if you have a patient with serious heart failure and arrhythmias and uncontrolled hypertension, it wouldn't make so much sense to risk the patient's life with BTK inhibitors. So in that setting, BCL2, venetoclax, would be a preferred option, although the responses appear to be lost with time in a substantial fraction of patients. So here you are weighing the benefits and the risks. And the risks, the stakes, are too high. Now, can we please move to our technical team? Can we have question number 5, please? Patient, age 64, in need of treatment. No deletion of 17p, no TP53 pathogenic variant, immunoglobulin genes are unmutated. Is the prognosis favorable, unfavorable? It depends, or I do not know. Please vote starting now. 10 seconds. 5 seconds. Let's close the poll. And can we have the results, please? So the majority said, in fact, favorable. And with that, I disagree. I will openly say that I disagree. Immunoglobulin unmutated have a poor prognosis. Now I see that 21% of you, but here I will disclose, including myself, voted it depends. And I would say that, in fact, in any poll of that kind, I would vote it depends. Dr. Damblage, do you agree with my preference or not?
And if you're committing to a BTK inhibitor treatment strategy, probably the outcome would be similar, whether it's mutated or not.
Okay, so let's have the next question and we will discuss both. Can we have question number 6, please? It's the exact same patient, 64, no deletion 17p, no TP53 pathogenic variant, immunoglobulin unmutated, no comorbidities. So would you give continuous BTK inhibitor treatment, fixed duration BCL2 venetoclax-based treatment, chemoimmunotherapy? It depends, or I do not know. Please vote starting now. 10 seconds. 5 seconds. Let's close the poll. So here we have 58% going for continuous BTK inhibitor based, but we do have also almost 40% opting for chemoimmunotherapy. Dr. Damblage, the floor is yours. How do you respond to that?
So, yeah, chemoimmunotherapy would not be an ideal treatment. In fact, I don't think it would be fair to expose patients to the toxicities of chemoimmunotherapy at this age and with the early and delayed toxicities associated with it, with the response that is considered inferior to BTK inhibitors. So this would be my preferred treatment option, a BTK inhibitor.
I fully agree with you for 2 reasons. From the CLL trial, FCR versus FC, we learned that patients with unmutated immunoglobulin genes had a very short progression-free survival. So it is something to always remember. But even more importantly, as I showed you during my presentation, very recently, the combination of ibrutinib plus rituximab proved to be far superior to FCR in these patients. So, in my view, unmutated immunoglobulin genes, even when the patient lacks a TP53 aberration, corresponds to aggressive disease. So chemoimmunotherapy should be avoided in this group of patients? Can we please move to question number 8? Our technical team, question number 8. The next one, please. Question number 8, not question number 7. Thank you. So, a patient age 59 in need of treatment. He has diabetes, no deletion 17p, no TP53 pathogenic variant, immunoglobulin gene mutated. What would you give? Continuous treatment based on BTK inhibitors, fixed duration treatment based on venetoclax, chemoimmunotherapy. It depends, or I do not know. Please vote starting now. 10 seconds, 5 seconds. Let's close the poll and please show us the results. Ooh, a truly split vote. Dr. Damlaj, if you don't mind, what did you vote?
So it's tricky. So it depends. It depends on what the patient's, what the other comorbidities, if there are any, and his performance status.
No other comorbidities, perfectly fit.
Perfectly fit. Then the next factor to consider is the patient preference and the coverage, the medical coverage that's available. Personally, I would favor a BTK inhibitor based. However, it may not be, it's important to recognize and have a good discussion with the patient about the associated risks with FCR, but also the associated benefits. This patient may have a chance at cure, and which could be as high as 60%. So I think for me, it depends on all the factors and a good discussion with the patient to have an informed consent. But that being said, I think very few patients would, from my experience, when they have an option of an oral agent versus intensive chemotherapy, very few would choose the intensive chemotherapy option. But nonetheless, it's still a discussion worth having.
Yep, I only differ with you slightly in one regard. I strongly dislike chemoimmunotherapy. You are right that some of these patients, because these patients represent a minority, please let's remember that. Yes. Okay, we are talking about fit,
mutated,
young, with immunoglobulin mutated genes. Do you know how many these patients are of all patients in CLL in front line?
15%, yeah, probably not more than 15%, probably.
It's 12%.
Yeah.
Yeah, we did the calculus in a huge series of more than 20,000 patients, and it turned out that there were no more than 12%. Now, just think of the bitter irony of a patient who is free of CLL for 10 years and then develops MDS or AML.
Yeah.
And do you know what? Together with Panayotis Balyakas, my close collaborator in Sweden, we ran a study where we had samples from patients who received FCR, and then sometime later, even many years later, developed secondary AML or MDS. We tested the AML MDS sample with NGS, and we found typical mutations associated with myeloid malignancies. So we went back to the sample before FCR, and guess what? The exact same AML MDS associated mutation, TET2, DNMT3A, whatever, was present at a very, very low frequency. This corresponds to what we call clonal hematopoiesis of indeterminate potential, CHIP.
So do we think these patients had the potential and we just accelerated it with the chemotherapy?
That's the most probable explanation. And in fact, now we have launched a study in Europe, and you are all very welcome to join. It's not restricted to Europe, it's a global study. So if you happen to have patients who were treated with chemoimmunotherapy and developed a secondary myeloid malignancy, I guess that at the time of AML or MDS, you run karyotype. So you must have cells from these patients. We would really be very happy to receive them, and you would be amongst our co-authors, because we do see, we've tested for the presence of CHIP untreated patients with CLL, and we found that almost 15% of untreated patients have CHIP.
Interesting.
So I would like to see the depth of chemoimmunotherapy across age groups and prognostic categories sooner rather than later. Final question, please. Question number 10 to our technical team. It's a lady aged 63, very fit, in need of treatment. No deletion 17p, no TP53 pathogenic variant. The immunoglobulin genes are mutated. She belongs, based on the immunoglobulin genes, to what we call subset number 2. So, how will you treat this lady? With continuous BTK inhibition, with fixed duration BCL2 inhibition with venetoclax, with chemoimmunotherapy? It depends, or I do not know. Please vote starting now. 10 seconds, 5 seconds. Let's close the poll. And can we see the polling result? Now, we have almost 50% opting for novel agents, 25%, 1/4 of us going for chemoimmunotherapy, and then it depends, or I do not know. Now, I will only say one thing, and then I will pass to you, Dr. Damlaj. Chemoimmunotherapy does not seem a great option, in my view, after the results that we obtained from the analysis of the chemoimmunotherapy trials. Do you remember the green line? Subset number 2, we're doing poorly, although they correspond to IG mutated CLL. So, if we take that out, then Dr. Damlaj, what would you say?
I don't think even the option, it depends. I'm trying to think. I cannot really think of any factor that would sway me to consider chemoimmunotherapy. I think a novel agent approach is the way to go in the subset number 2.
And I will disclose that I voted I do not know, because we do not have the evidence to prefer venetoclax-based versus BTKI-based treatment. And this obviously brings us to another important aspect that we should all, I believe, realize. More and more in CLL, as in many other cancers, through biomarker testing, we recognize subgroups that appear to be very distinct. So the obvious challenge here is, can we ever get solid evidence from randomized clinical trials? In a randomized clinical trial, you will have, even in a large one, you will have no more than 800 patients. So subset number 2 is about 5% of all patients in the front line. This means 40 patients in both arms. Do you anticipate having the solid results that the regulators and payers want in order to approve? And the answer is obviously not. So, in my view, this tells us something else. Endorsing the FDA and the EMA opinion that we need prospective, carefully planned, real-world studies. We need to see what happens in very large series in the real world. This means very close collaboration, and this is what we in the European Research Initiative on CLL like to do. We are really supporting real-world studies in CLL, and we would be very happy if our colleagues also from the Kingdom would like to participate in these studies. There is no other way for improving the outcomes of patients with CLL other than collaboration. So let's collaborate. This is the only way to advance the prospects of our patients and to really move the field forward. It's very easy to become members of ERIC, the European Research Initiative on CLL. It's free. You get the benefit of staying updated on any new development and being informed about every new study. Thank you really very much. And Dr. Damlage, I'm really indebted to you. It was a great discussion. Thank you very much for making it happen.
Excellent discussion, Professor Stamatopoulos. Thank you so much for being with us this evening. I'm sure all of us have learned lots. It was a lot more interactive than we usually have, so I appreciated this change. Again, thank you all for being with us this evening, and I hope you have learned lots as I have. And just again, acknowledging our sponsor for tonight. And our next SSBMT webinar is going to be 2 weeks away on the 30th of October. So please make sure to join us again. Again, thanks so much, Professor, and we hope to see you again in real time with us here in the Kingdom. Have a good night, and bientôt.
Are we in a separate room now?